and it is an honor to present to you today urinary tract infection in children. The outline of this presentation will cover overview of UTI in children, importance of diagnosing UTI, diagnosis and management approaches, and we will also go to imaging in UTI in the view of different guidelines. So we will start with an overview of common cause, overview of why the UTI is important. The importance of UTI is that if left untreated, it can result in morbidity, renal scarring, hypertension, and end-stage kidney disease. It is responsible for about 20 to 35% of children who have first febrile UTI. They might have associated VUR, and this is documented in River study in 2014. 10 to 20% will present with renal scarring at presentation. It is a preventable cause that might contribute to end-stage kidney disease progression. So that's why it's important to diagnose UTI. It is also responsible for presentation to the casualty for children who present with fever. The relationship between the number of UTI and the risk of renal scarring can be seen here in the study of River study in 2014. And as you can see, if you have 2 to 3 UTIs, your risk for developing renal scarring will increase. And with time, you might have a very high risk approaching 30 to 50%, and sometimes up to 70%. If we look at the UTI and the gender, UTI is common in male before 6 months of age. Usually in the first 6 months of age, the male have more risk than females. After 6 months of age, this will change, and it will decrease gradually until eventually the risk in the female will be after 1 year. After 1 year, the female will have more risk than males. This is important, and this is related to circumcision. In an uncircumcised male, the risk is high. After 1 year, the risk will be the female will have a more anatomical risk because of the short urethra, and so they will have a highest risk. Important definition in UTI. We need to look at this. We can talk about UTI according to the signs and symptoms. We can talk about UTI depending on the site of infection. We can talk about UTI according to the severity of infection, and we can talk about UTI according to the renal status. So if we look here, you can look at signs and symptoms. You will hear things, terminologies like febrile UTI, symptomatic UTI, and these are UTI associated with temperature, UTI associated with fever and urinary symptoms. And usually the temperature is not a regular high temperature, it is 38 degrees and above. Asymptomatic bacteriuria, sterile biuria, and these are terminologies usually used to define significant bacteriuria in a child with no symptoms of UTI. Sterile biuria is increased white cells in the urine in the absence of bacteria on urine culture. Important also in the UTI, the concept of bladder bowel dysfunction, which is known as BBD. It represents one of the risk factors, especially in children and toddlers. And this it's a terminology that's used to define a relationship of incontinence, constipation, encopresis, with how the lower urinary tract and the pelvic floor will function during urination. Making the long story short, it means that if you have constipation during the voiding, the bladder will not empty completely. There will be pressure on the urethra, and this pressure will make the urine pour stream, and it will not empty completely. And so for this reason, the risk of UTI will increase because we will have a residual an incomplete emptying of the urine from the bladder will start. If we look at the UTI according to the site of infection, we have lower UTI, tract UTI, and this is basically cystitis, infection of the bladder, and urethritis, infection of the urethra. In comparison to upper tract infection, which is involving the kidney and the ureter, and this is defined as pyelonephritis. Severity of infection, you might find in some literature terminology like complicated UTI, and it means that we have UTI either in a newborn or a UTI with atypical clinical course, including absence of clinical response to the antibiotic within 72 hours, abdominal or bladder mass, abnormalities in the kidneys and urinary tracts, or all these UTIs will need to be considered as complicated UTI. Complicated cystitis, these are patients who have sterilization and a lot of surgical interventions. According to the renal status, you might define UTI as reflex nephropathy. These are people who have associated VOR. And renal scarring represent a specific entity that is outcome of the acute pyelonephritis. With all this terminology, the most important terminology that we need to know is recurrent UTI. When we say the word recurrent UTI, we mean more or 2 episodes of acute pyelonephritis, or 1 episode of acute pyelonephritis with 1 episode of cystitis, or repetitive lower UTI in cystitis pattern. And this recurrent UTI is very important because we need to manage and we need to prevent. Risk factors for UTI, according to the guidelines, the American Academy of Pediatrics 2011, they are defining the risk factor for UTI as the white race, age less than 12 months, temperature 39 degrees and above, fever for more than 24 hours, absence of another source of infection, uncircumcised male. And these are risk factors for UTI, and we need to be having high index of suspicion to diagnose and to treat UTI. Diagnostic approach to UTI, let's start with the history. We need to have a focused, targeted history and examination. In the history, we need to look at a pattern of recurrent fever without a clear focus. And actually, UTI is in the differential diagnosis of fever of unknown origin, because most of the primary doctors, they can miss this diagnosis because they cannot make a clear approach to the diagnosis, as we will see. History of recent UTI and treatment. If you have a child who is presenting to the casualty every time, and sometimes they are giving him treatment for UTI, but without urine culture, we need also to put this in mind. You need to put this in the history. Detailed voiding history. We need to look at the voiding history, how the child is voiding. Is having clear stream, poor stream, hesitancy, urgency in older children. So we need a detailed voiding of history, how many times per day he is voiding, if there is any kind of incontinence, and also we need to document constipation. We need to ask about circumcision. In areas where there is antenatal diagnosis, especially in neonates, we need to ask about prenatal scan, if there is any renal abnormality. And we need to ask about family history of renal disease and other children with VUR, because there is a genetic predisposition. If we look at the symptoms of UTI, it depends on what age you are talking about. In children who are 3 months and below, these children they present with non-specific symptoms. They can present with fever, vomiting, lethargy, irritability. This might progress to poor feeding, failure to thrive, and they can present with abdominal pain, but it cannot be related to the physician. And so for this reason, so for this reason, we need to have a high index of suspicion in children who are less than 3 months. In older children who are 3 months and above, those are who like toddlers, for example, still they can present with non-specific symptoms, only fever. Okay, irritability, vomiting, these are late signs. But they might also present with lower abdominal pain, and we need to suspect UTI. In patients who are verbal, above 5 years and above, we have the symptoms of dysfunctional voiding, urgency, hesitancy, poor stream urine, and they might progress to severe fever, toxic patient with vomiting and hematuria. Changes also in the urine color in these children are common. So these are the symptoms for UTI. Okay, important differentiation in UTI, we need to differentiate between two conditions. We need to differentiate between acute pyelonephritis and uncomplicated cystitis. This is very important. In a child who is presenting with features of severe sick child, lethargic child, high-grade fever with flank pain or tenderness, we have to suspect shivering and high-grade fever in this child. This child most likely might have acute pyelonephritis. Okay, and in this case, the management is different from simple or uncomplicated cystitis. Usually, the differentiation between acute pyelonephritis and uncomplicated cystitis, as you can see, it depends on the symptoms. If you look at the symptoms, people with acute pyelonephritis are more toxic. They have high-grade fever. Okay, they cannot do their usual day activities. Okay, they will be bedridden at some point. If you look at the symptoms, also they have flank pain. Usually, the commonest organism involved is, while in cystitis, you might have other organisms. You might have viral cystitis, fungal cystitis, chemical cystitis. You might have simple trauma that's causing also cystitis. The urinary findings in patient with acute pyelonephritis, you might have hematuria is uncommon. Okay, while in cystitis you might have some fresh blood. The urine is both. Ultrasound kidneys, non-specific in both in acute pyelonephritis and uncomplicated cystitis. And so the differentiation of acute pyelonephritis and uncomplicated cystitis based on imaging, as we will see later, is not easy. Okay, to differentiate between acute pyelonephritis and uncomplicated cystitis, you might do a DIMS scan within the first 3 to 7 days while the fever is present. And usually DIMS scan is considered as an invasive procedure because it needs to have resources to do it. The resources might not be available. And so we need to depend on our clinical suspicion and clinical judgment to differentiate and make this differentiation. Okay. Blood test, as we will see later, also might help. Another entity we need to look at is asymptomatic bacteriuria. Sorry for the B. And asymptomatic bacteriuria is meaning colonization of the bladder in the of an inflammatory reaction. People who have asymptomatic bacteriuria, reported incidence is around 1 to 3%. It usually resolves spontaneously. To suspect asymptomatic bacteriuria, you need to have a history. People who have, for example, neurogenic bladder, people who have repeated changing of the catheter, people who are on vesicostomy, for example, and if you did for those people a urine culture, it will come positive every day. And so, although that the culture contains some organism, still there is no symptoms. And so this represent asymptomatic bacteriuria. So for children who are presenting with such conditions, you need to have, if you have a full-blown picture of fever, abdominal pain, at that time you need to suspect that this is UTI and it is not asymptomatic bacteriuria. Antibiotic treatment is not recommended in asymptomatic bacteriuria. It will create resistance. It will create unnecessary side effect of antibiotic. Physical examination in a patient with a UTI. If you would like to do a physical examination, which is an important part of the diagnostic approach, you need to start by vital signs and general condition. People who have long-standing recurrent UTI, they might have abnormal growth, they might have hypertension. So you need to look for this. Abdominal examination, you will look for abdominal distension, palpable masses, constipation, flank tenderness, suprapubic tenderness, palpable urinary bladder in patients who are presenting with bladder outlet obstruction or BUB. Examination of the external genitalia and the back is very important in every child who is suspected to have a UTI. You can have this image is showing for you vaginal adhesions, and this might predispose to UTI. Okay. Also, you need to examine in male, you need to examine circumcision. If he is not circumcised, you might find that he have hemosis. Examination of the back, you need to look at sacral dimples, you need to look at spina bifida occulta, you might find meningiosy, and these are associated with abnormal innervation of the urinary bladder, and they might predispose to neurogenic bladders. And this in turn might lead to recurrent UTI. So we move on to a method of urine collection in children with who are suspected to have UTI. Methods of urine collection can be divided into non-invasive method and invasive method. The non-invasive method is nappy pad, urine bag, specimen, and clean catch urine. These are non-invasive, and usually in a patient who is suspected to have UTI, avoid doing nappy pad or urine bag, okay? Because the high risk of contamination in these methods are very high, and it is not reliable. Although it is convenient for the parent because he will not have to worry about how he will collect the urine, but it will lead to false positive results. One of the important methods is the invasive methods, which are either doing urinary catheter or either doing suprapubic aspiration. And if you look at the contamination rate in the suprapubic aspiration and the catheter, they have the less contamination rate. And so the suprapubic aspiration is contamination rate is 1% or below. And in the catheter, the contamination rate is around 10%. So these are useful methods to avoid contamination. On the other hand, if you come to a parent and you said, I want to introduce a catheter, or I want to do suprapubic aspiration, especially in neonates, maybe they will be stressed and they will refuse. And so this is one of the disadvantages of catheter and suprapubic aspiration. So you need to counsel the parents about that, why it is important to do this, and you need to do it in expert hand and in a comfortable area. One of the commonest methods we use in children who are 4 years, 5 years and above is the clean catch method. And actually the clean catch is the same as midstream. So we will try to do a clean catch we are doing while we are trying to from midstream of the urine after we clean the urethral area, right? As we will see. Okay, so this is the urine collection methods. This is midstream urine collection methods. This is described by Labrosi in 2016. They tried to take midstream urine or clean catch urine from this child who is less than 3 months. Okay, basically 2 persons will come. Some will hold the baby from behind, okay, and he will fix his upper limb. Another will come and try to fix the lower limb, they will separate the lower limbs. Someone will come, a nurse will come and clean the area, okay, and then most likely the child will try to pee and urinate, and you will take the midstream of the sample. Another method that is described by in a BMJ journal, they call it a quick wee trial. And basically a quick wee trial is to make the child, while he is lying down, you try to get a piece of cotton and you try to round it around the suprapubic area. Okay, after less than 5 minutes, the child will urinate, and so you will be opportunistic and you will take the sample. So these are one of the methods that's commonly used. Importance of urine collection. Why is it important to look at the urine collection? Because we need to avoid overdiagnosis of UTI, and we need to avoid also underdiagnosis and missing a case of UTI. So if you take a urine collection with urine bag and you send it for the culture, that's for sure the culture will become positive, but we know that this is contamination. It is not actually a true UTI. So if you treat in this case, you will be treating unnecessarily. Okay. At the same time, if you didn't take a good urine sample, you will never know if this patient had the UTI or not. And so it is important to be very careful when you are trying to collect the urine. Also, you need to be careful about how to send the sample for urine analysis. If you let the urine stay in the room temperature, bacteria will try to colonize the urine immediately, and it will give you a false positive result. If there is any suspected delay to the laboratory, you need to keep the urine refrigerated in 4 degrees centigrade, or you put ice water within the bottle of the urine, and then you send it to the lab. Okay, diagnosis of UTI is simple. It will just need to do urine examination, urine microscopy, and you will do urine culture. It is as simple as that. Okay, we don't need, this is for a diagnosis of uncomplicated cystitis. Okay, examination of the urine, you can look at the urine color, you can ask about the urine smell, and you can do urine dipstick. Actually, when you send the urine to the laboratory, they will do urine dipstick, and then they will do microscopy. So in the urine dipstick, we need to look at leukocyte estrase, nitrate, we look at white blood cells, and we look at the bacteria. As you can see here, in the urine dipstick, if you have a positive nitrate, and if you have a positive leukocyte estrase, at the third column here, at the third row, the sensitivity and specificity is around 93% and 72%. So for this reason, urine dipstick can be helpful, especially if you have leukocyte estrase positive, nitrate test positive. Okay, in this case, most likely, the suspicion and probability of UTI is high. Okay? If you have leukocyte estrase, nitrate, microscopy positive, also the sensitivity and specificity are very high. And these are the parameters that we depend on in the urine dipstick. Okay. So if you look at this table, it will analyze for you that if you have both leukocyte and nitrate positive, the probability is high. If you have nitrate only positive and leukocyte negative, still you can start antibiotic and you wait for the urine culture result. Okay, the possibility is there, but it is not very high. If you have nitrate negative and you have like a leukocyte positive, you will not start antibiotic unless you have a good evidence by clinical suspicion or clinical symptoms. Wait for the culture. Nitrate and leukocyte are negative. This is not a UTI. You need to look for other causes of fever. You will send urine for microscopy, and also you will also send for urine culture if you have suspicion, okay, based on clinical. If the child is, for example, urinate and he is having burning micturition, in that case, you can send for urine culture, although the leukocyte negative and nitrate is negative. Urine microscopy. Actually, we look for urine microscopy in selected cases where you need to look for you have bacteria and you have total WBC more than 5. And actually, the WBC usually, if it is more than 10, it represents pyuria. And so there is some evidence that most cases of UTI, if not all, will contain high WBC count in the urine and bacteriuria in the urine. So some people, they are favoring that in cases where bacteriuria is positive and pyuria is positive, this is most likely it is a high probability for UTI. If you look at the guidelines, what is the guidelines are saying? These are guidelines from different authorities. As you can see, you have the NICE guidelines, you have the American Academy of Pediatrics, you have the Italian Society, you have also this is being guidelines, you have the European, you have the Swiss guidelines. All of these guidelines, they have different specification for urine collection in non-towel trained children and the significance of bacteriuria in the urine culture. Okay, and so you need to familiarize yourself with what they are saying. Okay, for example, if you look at the American Academy of Pediatrics in 2011, they are favoring that bladder catheterization or suprapubic aspiration, especially in children aged less than 2 years, they are the favorite method for UTI. And if you look at urine culture, they are saying that if you have a urine culture by catheter, okay, if you have 50,000 means 50,000. If you have 50,000 colony per mil, this is significant bacteria. That is for sure a UTI. Okay, and this number is changing in other guidelines. For example, in the Italian guidelines, you will find that the catheterization, if you look at the colony unit, it will be around 10,000, يعني 10,000 in a clean voided, in a catheterized sample. Okay, while it is around 100,000 in a clean voided urine. Okay, so each guideline, each authority and each society, they produce their own guidelines. Okay, so you need to familiarize yourself with these guidelines. Diagnosis of UTI. From what we have said, the diagnosis of UTI, the gold standard to diagnose UTI is by an evidence of positive urine culture. Okay, you will have urine dipstick and urine analysis and microscopy to help you in the probability and suspicion and build your suspicion for UTI. Okay, blood investigation like CRP, renal panel are routine. Okay, if you are suspecting uncomplicated UTI or simple cystitis. Okay, so in this case, you will not do CBC. Okay, CBC and RB and renal panel might be helpful in case of biopsies. What are we looking for? We're looking for a high total WBC count. We look for high CRP, and we look for elevation and changes in the renal profile, namely the function of the kidney with the urea and creatinine. We move on to the role of imaging in children with UTI. What is the goals of imaging? Why are we doing the imaging in UTI? We are doing the imaging to identify people who have underlying structural kidney abnormality, like obstructive uropathy, for example. Also, we are trying to look for factors that predispose children to recurrent UTI and increase the risk of recurrent UTI. Also, we are looking for people who have kidney parenchymal damage. Okay, people who have severe or bilateral disease. Okay, predisposing them to increased risk of hypertension, preeclampsia, and pregnancy. Okay, so in a child who have recurrent UTI and hypertension, you need to do imaging. We need to look for kidney scars. Okay, and it is very interesting also to look at the relationship in a female child who is having a renal scar, they have high risk of preeclampsia. Okay, and there is this new evidence that preeclampsia can be going to the fetus or her future children. Okay. Kidney, we will start by modalities of imaging. We need to look at the kidney and bladder ultrasound. This is the simplest one. Okay, it is non-invasive procedure. It gives you information on the kidney size, shape, bladder size, and wall thickness. It will give you information about the ureteral dilatation and pelvic-calyceal system. The recommendation, and this is the recommendation of the American Academy of Pediatrics, in children who are less than 24 months, you need to do kidney ultrasound following a first febrile UTI. Okay, all children with suspected upper tract UTI, which is UTI in the upper tract, like pyelonephritis, they have to have ultrasound. Okay, children with recurrent UTI, as we said in the definition, they need to have ultrasound. All children with the UTI who have poor growth, hypertension, symptoms suggestive of urinary tract obstruction, family history of abnormal urinary tracts, congenital anomalies, they need to have those to antibiotics, either oral, or if you started an IV, they need to have a bladder ultrasound. So this is the recommendation when you are considering kidney and bladder ultrasound. VCUG or MCUG, which is voiding cystourethrogram or micturating cystourethrogram. This investigation will give you important information about the bladder, the shape of the urethra, and competency of the vesicureteric junction. And if there is any abnormality, it will show you the VUR, which is the vesicureteric reflux. Okay. Radiation minimization protocol should be used in infants and young children. Can be performed after the acute phase of infection. If you have a child with a UTI, now you cannot do MCUG unless you have completely treated him. And after the resolution of the infection, you need to bring the child and to do for him MCUG, and you need to give him prophylactic antibiotic on the day of the MCUG. Before 1 hour before the MCUG, you need to give prophylactic antibiotic. Okay. So the recommendation for MCUG, and this is again from the American Academy, you need to look at children who are less than 2 years with a first febrile UTI, and especially infants whose infection were serious at presentation. People, they need MCUG. Okay. In boys of all ages with presumptive upper and lower tract UTI and ultrasound abnormality, you need to have MCUG. So if you have a child with pyelonephritis, or you have a child who has cystitis, but for example, you did kidney ultrasound and the kidney ultrasound showed you hydronephrosis. This child, you can do MCUG for him, and it is recommended to do MCUG. Okay. In girls more than 2 years, and those who are less than 6 years with complicated UTI or recurrent UTI, this is an indication. And in girls who are above 6 years with complicated UTI or recurrent UTI plus a scar on the DEMSA scan. Okay, so this is the recommendation from the American Academy of Pediatrics. We move also to the third modality of imaging, which is the DEMSA. The DEMSA stands for dimercaptosuccinic acid. It will be done by nuclear scan. You inject a dye, the dye will be, the patient will be photoed by gamma camera, and according to the radiation and the radiation from the dye, you will make the curve, and then you will see and look at the kidneys. And the DEMSA scan will show you the area of in the kidney. Okay. In cases of pyelonephritis, DEMSA scan is useful, but DEMSA scan is what you are saying is sophisticated investigation. It needs to have, you have resources to do it. And sometimes if you can make the diagnosis of pyelonephritis clinically, there is no need for DEMSA. In the acute stage of pyelonephritis, in the first 3 days, it is recommended to do DEMSA scan if you would like to confirm the presence of pyelonephritis. Also, DEMSA scan is useful in showing us renal scars in patients who have recurrent UTI. Okay, and usually the scar will not be shown, it will show within 3 months or after. Okay, so if you have someone who have pyelonephritis and you have treated him, you will not do DEMSA immediately. You will do DEMSA after minimum of 3 months to look for kidney scar. Okay. Also, the DEMSA scan will give you differential function of the two kidneys. Okay, so the recommendation for doing DEMSA is for children who are less than 2 years with febrile UTI. This is one. And for children who are above 2 years with clinical evidence of acute pyelonephritis or complicated UTI or recurrent UTI. Okay. Okay. So DEMSA is a long-term investigation. It will help you in looking at the patient on the long term, and if he develops renal scar, we need to look for risk of hypertension and to see and to counsel the parents about possibility of chronic kidney disease in the future. So in general, to sum up the approach to imaging, there is two approaches to imaging. Either you can go on what is called a top-down approach. The top-down approach, you start from above, okay, and then you go to below. Okay, in the top-down approach, if a child who is presenting with febrile UTI or recurrent UTI, as we said, some people might start by doing DEMSA scan, okay, with the renal ultrasound immediately. And then based on the result of the DEMSA scan, if they found the scar, they might consider doing MCUG. Okay, if there is no scar, the doctor will not proceed to do MCUG. So this is known as the top-down approach. Another way of doing the imaging is bottom-up approach. And bottom-up approach means I will start from lower to upper. So if I present with febrile UTI, some people will do renal ultrasound with an MCUG. If the MCUG is significant, they will do DEMSA scan. Okay, and so if you are a clinician, the people who are favoring the top-down approach, they are trying to say the radiation from the MCUG is high and no need to do predispose the child for radiation. While in the DEMSA scan, there is no radiation. Okay, so this is their rationale. And in the people who are saying that we would like to start bottom-up approach, in those doctors, the rationale is some people with VUR might be missed, and that VUR is important contributing factor to current so they want to discover VUR. Okay, and with now in 2022, there are some evidence that the bottom-up approach is not actually the rationale for bottom-up approach is not very solid. Okay, who have recurrent UTI, a small proportion of them will have VUR, and for those who have VUR, not all of them will present with recurrent UTI, and all this is under study and under research. Okay, we move on to our last part, the treatment. Treatment of UTI need to be started by general management. You have to have a very good history so you can instruct in the general management about things like infrequent voiding. If the child is not going to the toilet 2 to 3 times or 4 times per day, okay? In this case, this pattern frequent will precipitate UTI. Why? Because there will be some residual urine in the bladder and urine holding. This will favor the growth of bacteria in the urine. This is number one. Constipation, very important of UTI is to do what's known as bladder and bowel diary. It's very important to ask in the history about the pattern of how many times this child is going to do a stool or to defecate. Okay, because If he is not going regularly, constipation is a high risk for UTI. You will be surprised what is defined by the mother regular, what is defined by the mother of constipation. You might ask a mother how many times he goes, she will say for you regular, no problem. When you say for her how many times per day, she will say once every 3 days. Some of them will say once every 4 days, and they are considering this as normal. So when you are trying to look at the constipation, you need to be very specific. How many times he go? What is the consistency of the stool? You have the Bristol chart. I advise you to go to the Bristol chart to look for this one. And if you find that this child is constipated, this might be a very important reason for his UTI. As we said, examination of the external genitalia. Look at this one, phimosis and adhesions. Also, you need to look at how the mother is cleaning her child. In children who are less than 3 months, the way to do a good hygiene is important. And they have to, as we will see, they have to clean the child from front to back. Okay? So, the general management also involves high fluid intake, timed voiding. You need to have high fluid intake. You need to have timed voiding. Timed voiding means that the child needs to go to toilet every specific time. Okay, he should not be distracted by playing. He should not be just missing his voids because he is not, no one is watching. Prevention and management, as we said, perineal hygiene, proper to back in girls, keeping the perineal region dry, wearing cotton underwear, avoiding bath, it can cause vulval and itching. Antibiotic treatment, as we said, simple. Okay, so if you look at the antibiotic treatment guidelines, different guidelines have different recommendations, but in general, in a simple cystitis, you oral. Okay, in a patient who have pyelonephritis, they need to have IV antibiotics or parenteral. Okay, and also if the child is not taking well, if he is vomiting everything, at that time you have to consider also giving this child parenteral. Okay, regarding the duration in patients who have lower UTI, it is between 3 to 5 days. Okay, some authorities, they are saying even 2 to 4 days, like for example the Canadian. Okay, if you look at the upper UTI or pyelonephritis, you have to treat for at least 7 to 14 days, which is 1 to 2 weeks. And this is very important, and it has to be parenteral. Okay. So this is about the antibiotic. Some people might ask about antibiotic prophylaxis, and actually antibiotic prophylaxis is beyond the discussion of antibiotic prophylaxis is beyond the scope of this presentation, but you need to familiarize yourself because in specific children who have UTI recurrent with multiple risk factors like VUR, like neurogenic bladder, okay, and they have frequent UTI, in these cases, there is a recommendation and guidelines for antibiotic prophylaxis, okay? In general, the recommendation for antibiotic prophylaxis is in infants and children prior to MCUG, as we said, okay? Starting on the day of the procedure, and some people will continue for 3 days, okay? But usually our approach is to give 1 hour before the MCUG. In children who are less than 2 years with dilated VUR, until at least 2 years after febrile UTI. In children who are more than 2 years with dilating VUR and febrile UTI, until at least 2 years after febrile UTI. Children with recurrent UTI who have non-dilating VUR, okay, this is also are considered for antibiotic prophylaxis. Children with recurrent UTI until 6 to 12 months infection-free. So the antibiotic prophylaxis, there is no general rule. You need to look at the age of the patient. You need to look at the risk factor. If he has VUR, you need to look at the grade of the VUR, okay? And then you need to see how many times this child has developed UTI. If he has a simple cystitis with a grade 1 and grade 2, okay, we just need to monitor and follow up. If he developed febrile UTI like pyelonephritis, in this case, I might consider we have to give antibiotic prophylaxis, okay? So this was our last slide. I hope that the presentation was useful for you, and thank you very much for your listen.
شكرا